Assalamu alaikum. So today I'm going to show a routine case of eco-emulsification. I'm making the main incision with the 2.75 mm keratome. In this case, the thing I want to emphasize most is the importance of anterior capsule polishing. If you thoroughly polish the anterior capsule margins, then the chance of a secondary procedure such as a yak capsulotomy decrease significantly. So injecting viscoelastic into the anterior chamber. Each viscoelastic has a different property. So if you inject HPMC, then it will you will have a different feeling when creating a capsular rhexis than when you use chondroitin sulfate or sodium hyaluronate. So each viscoelastic behaves differently in the anterior chamber. So I find HPMC I'm most comfortable with the HPMC when performing the capsular rhexis. The only disadvantage of HPMC is that it is difficult to remove it from the anterior chamber. It sticks to the corneal endothelium, and so you have to spend a lot more time and pass a lot more fluid through the eye to remove it completely, especially if you inject an intraocular lens using HPMC. Here I'm doing the eye dissection. Every step in phacoemulsification is connected. If you do not perform one step correctly, then it will start a cascade of events which will cause problem later in the surgery. As you see, the anesthesia in this case was not that effective, and tried to in this case the sleeve on which was on top of the needle is much larger than the needle, and it was proving a little difficult to enter into the eye. So I remove the air bubbles and I start to proceed to do a direct chop technique. The nucleus in this case, as you see, is slightly on the softer side, grade 1-2 nucleus closis, and there I get the first chop right. However, the second chop, there was a problem with the phaco machine, and for some reason it stopped working. So here I try again, but the machine is not working. So I pull the needle out of the eye and ask my technician to fix it, and he's fixed the problem. So now I proceed again, trying to chop the pieces in. For grade 1, grade 2 nucleus closis, you only get a single chance to chop the pieces, and here I'm successful in chopping a small piece. Divide it again, and so now I've very small about I've eaten up a heminucleus, and this is the epinucleus sheet, and I carefully emulsify the remainder of the pieces. I usually make a very small side port to prevent leakage and to have a more stable anterior chamber. I think it's always wise to spend a minute or two extra to thoroughly polish the capsular bag. I think it is also important to center your axis appropriately and make sure that it overlaps the optic of the IOL 360 degrees. This is an also precautionary measure to prevent posterior capsular opacification. So trying to remove the cortical sheets using a Simcoe cannula, and at this point most of the cortical sheets have been removed. However, the bag needs a lot of polishing, so here I'm now starting to clean the under surface of the anterior capsular ring, which is a very important step, probably one of the most important steps to avoid a secondary posterior capsular opacification in the future. And here I'm continuing to try to remove the muck underneath the anterior capsular rim. This is a completely unedited surgery. Now as my technician gets ready to load the IOL, actually it was a 5.5 millimeter hard PMMA lens, and therefore that is the reason for the limbal limbal incision, or you can say as partially scleral tunnel incision. And here lens is being so at this point I was unsuccessful because Rex inserting the IOL in the capsular bag, so I decided to take it, and here done. So now as you can see the rexis is perfectly overlapping the optic. That was my intention, and now as you can see I've polished the under surface of the anterior capsule in the temporal area, and now I am going to polish the under surface of the anterior capsule in the nasal part of the eye. So here you can see, you can now appreciate the muck more easily that I'm trying to clear up. And here I'm trying to clean the muck on the under surface of the anterior capsule. I want this patient to have the best possible results. I think the capsular bag is sufficiently clean. So now I close up the case, and Jazakallah. Thank you so much for watching. Please give comments and suggestions. Jazakallah.